Thank you, Joel. That's very sweet of you. Yes, it's been a long and perhaps strange road. The last 27 years that I've been here raising a family in Sarasota, practicing a lot of neurology, and during the past 4 years, adding cannabis therapeutics to what we offer our patients. And perhaps notably, I should say that we closed our neurology practice this past September. There was a combination of factors that led to that decision, not the least of which was increasing demand from cannabis-related issues in patients and talks, and decreasing satisfaction with doing remote neurology as a result of COVID. So anyway, we are full-time cannabis providers now, and it's been great. It's been great. It's not boring. So just by way of adding to the introduction a little bit, and I won't go into too many details here, but I think say that when I was 18 years old and I was at the University of Rochester, my first course, first semester, was with Professor Dale McAdam, and it was called Man's Plastic Brain. And I remember having one of those aha moments where learning about the nervous system and behavior and neurochemistry just fits so beautifully into my interests at that time, which included why cannabis does what it does. And so I just want to give a shout out to Dale McAdam. Well, anyway, then of course things continued from there, and I won't bore you too much with that. In fact, I think someone may have just clicked the skip intro button on the bottom right, so we'll just go to the next slide. Now, in April 2017, I started studying in earnest the endocannabinoid system. Why? Because Florida Amendment 2 had passed the November before, and my patients were asking more and more about cannabis now that it was sort of out of the closet. We had taken care of many, many multiple sclerosis patients over the year, and as a population, they were early adopters in cannabis therapy. They discovered that it was helpful for muscle spasticity, and a few of them were brave enough to volunteer that information during our visits, even though it was not fully legal at all at that time. Well, it turns out that, of course, they were right, and subsequent studies performed in London and around the world, sponsored by GW Pharmaceuticals, led to the approval of Sativex, not in the United States, but in at least 16 or 17 other countries, for the use of CBD and THC as a spray for spasticity in patients with multiple sclerosis. And I was like, wow, this is real. This is science. This is randomized controlled trials that they financed, that have been reviewed by numerous regulatory boards. And yes, Sativex works, cannabis works for spasticity and multiple sclerosis. We also learned soon after that cannabis was effective as CBD for young people with epilepsy. And that has subsequently been approved by our FDA in the form of Epidiolex. So here I am, it's April, my patients are asking for it, and the law has been passed, and so I started studying it, and I was amazed. I had one of those Dale McAdam moments where the neurochemistry of it just made so much sense, and taking what I knew about patient care and what they were dealing with, and combining that with lots of work that was being done on the neurochemistry of how cannabinoids worked in the brain and body, it just made sense to me. It was biologically plausible. It was real. It was believable as an academic and clinician. And so I felt comfortable at that point proceeding with our clinic, opening our doors and making cannabis therapy available to our patients. It was no small feat. I was nervous. I didn't know how many milligrams of this or milligrams of that would either help or hurt somebody, but fortunately, there was a lot of information available on the internet to study cannabinoid effects in humans. Dustin Sulak, a physician up in Maine, had published numerous articles and videos with specific milligram suggestions on how to treat patients with cannabis. And so that gave me a lot of confidence. Of course, since 1996, cannabis was available as medical treatment to residents in California. And we had quite a bit of information there, real world information about what was working and what was not. And so learning about cannabis from a scientific point of view for me was very important. And I hope that at the end of this talk, you all will feel more confident exploring this as a therapy that is not voodoo. It's not snake oil, it's cannabis oil, and it makes biological sense. And even though it doesn't fit into the one molecule paradigm that we all were raised to believe in as medical students and fellows, as plant medicine, it provides an opportunity for us to widen our therapeutic horizons and learn more about how multiple molecules can help patients. So in 1964, Professor Meshulam, Raphael Meshulam in Israel, was able to elucidate the structure and synthesize delta-9 tetrahydrocannabinol, THC. Now, we had known about THC prior to 1964, but it was Professor Meshulam's hard work that allowed research to go forward after that point into the molecular biochemistry and clinical effects of delta-9 THC. Now remember, THC is the part that gets people high. It also has lots of other effects and is an important part of the plant. And I'm going to try and not get too deep into the weeds, about the molecular biochemistry of cannabinoids, but I will be sprinkling some of that here and there. I just can't help myself. So Professor Meshulam did this work early on, and he discovered with researchers in Brazil that CBD was effective in reducing seizures in children. And this was, in any other universe, a landmark achievement. But for some reason, social and political problems, for some reason, we were not able to adopt cannabis as a therapy. No pharmaceutical company was interested in testing it. And all those kids with epilepsy that could have been helped after 1970, let's say, continued to suffer until Epidiolex was finally approved a couple of years ago. So that's a shame. Nonetheless, the work went on. And in the late 1980s and early 1990s, workers here in the United States at St. Louis University, Alan Hallett specifically, discovered that there was a receptor in the brain that binds the THC molecule and was able to exert its biological effect in the brain. So this was an important finding. What came next was the elucidation of the endocannabinoid system. And the reason we learned about that was because those receptors in the brain were not put there in order to bind plant material. They were put there by the great designer, and she was very bright about this. They were put there to bind molecules in our own bodies. These chemicals we call endocannabinoids because they're inside our bodies, endo. The same way that endorphins are chemicals in our bodies that bind the same receptors that morphine binds. So shortly after Alan Hallett's work, Bill Devane in 1993, of blessed memory, discovered that in our bodies we had a molecule that he called anandamide, which means bliss in Sanskrit. The chemical word, I want to say it, but I'm not. It's like 7 or 8 syllables. If someone asks, I'll say it, but all right, I'll say it. Arachidonyl ethanolamine, or anandamide, was discovered, and then another endocannabinoid, 2-arachidonyl glycerol, I'm sorry, I can't help myself, 2-AG, was discovered, and then all these other molecules were discovered as part of what's in our bodies, binding those receptors that also bind phytocannabinoids, or the cannabinoids that come in the plant. So what we've learned now is how cannabis, which has been around for thousands of years, affects us biologically. And we have been able to study that quite carefully over the past 20 or 30 years. Now, the next phase of cannabis research is taking off, and we are learning that in addition to anandamide and 2-AG, there are other molecules in our brains and bodies that are basically lipids that act as signaling molecules. Now, when I was in medical school and residency, we didn't know any of this. There was not a single mention of any of this. And so there's a lot of trepidation, I think, amongst the old guard of medicine to embrace cannabinoid medicine simply out of ignorance. And I would implore you out there in the medical and healthcare field to look at what's available in terms of hard science data showing not only about phytocannabinoids but endocannabinoids, and I'll discuss some references later, because this train is just leaving the station. We are learning about lipid signaling molecules now that also have an effect on not just neurons, but bones and other tissues in the body. For example, we've learned recently that in the Mediterranean diet, as a result of the oils, we believe, that are in that diet mainly, there's a reduced risk of osteoporosis. And I think it's oleoserine, it turns out, acts similarly to anandamide as a molecule that binds to receptors on bone. And so what we learned as neurotransmitter biology, where serotonin or dopamine are contained in these little vesicles and then swim across the synaptic cleft and bind on postsynaptic receptors, that's only a very small part of the cell-to-cell communication story. We're learning now that lipids act as transmitters, and we'll learn more and more about that all the time. So my take-home message here is the endocannabinoid system is real, and don't wait another day if you're interested in learning more about it. There's plenty of information out there. Now, why do we as clinicians, other than just academic interest, need to learn about this? The answer is, of course, because our patients need us to. And I would like to just tell you a story about a patient named Gloria who is going to be your patient someday. You're going to walk into a room and someone named Gloria is going to say, "May I use this cannabis preparation? It's called Super Lemon Haze. Can I use this cannabis to help me sleep?" And you're going to say, "Well, Gloria, I'll tell you why that's not a good variety of cannabis for you. Super Lemon Haze has a high content of limonene, which is one of the terpenes, and has more of an energetic effect on people. So that's a flower that we suggest for patients for daytime use. If you want to sleep, maybe you should use something like 9-Pound Hammer." Now, these names are kind of ridiculous, but they are the common names of the different varieties of cannabis, which the scientific community likes to refer to as chemovars, chemical varieties, or cultivars. The growers talk about different cultivation varieties. And we try to be specific about what molecules do what in each variety. But the public in general uses these names, and I think they're fun and they mean things most of the time. But the truth is that 9-Pound Hammer grown in Washington State doesn't have the same chemical makeup as 9-Pound Hammer grown in Sarasota, Florida. Not that I know anything about growing. I'm just saying that the chemical variety is different because it has different constituents. And I would love to talk more about these terpenes at some point, but then that's getting into the molecular biochemistry. I'm going to stop right there. Back to Gloria. Now, she's going to ask you about cannabis because she'll feel comfortable asking a question about a legal option. In the United States, as a result of this past November's election, we now have 14 or so states that allow for recreational or the preferred term adult use cannabis. That number is changing a little bit. South Dakota recently found that the vote was not constitutional. Mississippi, which recently voted for medical, the dark green represents the medical states, the brown is the adult use along with medical. Mississippi is having some issues with their situation having to do with cannabis legality, but the point is there were half as many states 2 or 3 years ago than there are now. And it's not just in the United States. Worldwide, cannabis is being accepted as a safe alternative that the governments can no longer restrict. And here we have a map of the world showing that in blue, cannabis is legal for adult use countrywide in Canada, for example, South America, and then that's Uruguay over there in South America, and Georgia up there on the east coast of the Black Sea. We have in our country the 14 or so states that in blue represent adult use, and the green is medical use. And you can see the green in the other countries are legal for medical use countries. And so this is sweeping the world. And this is not new medicine around the world. Just as a historical point, cannabis was fully legal around the world for medicinal use up until about 100 years ago, when in the United States there was a strong push for prohibition of cannabis use. And subsequently in the 1960s and 1970s, there was a worldwide treaty, it's called, on substance use that requisitioned all the countries to come on board and not allow cannabis use. And so that UN treaty is now being pulled apart so that countries feel free around the world to enable their citizens to use medical cannabis and, for that matter, adult use cannabis. And we will see Mexico turn blue in the near future. Their lower house of parliament, I believe it's called, voted in the affirmative for countrywide approval of cannabis use, and now it's going to go to their Senate, and the president of Mexico has already verbalized his approval of that measure. So the entire country of Mexico is going to be blue for adult use. Canada went blue in October 2018, and the United States is turning blue. So guess what? Gloria is coming, and she's going to ask, and you all have to be ready to answer questions. If you're not, just call me, I'll help you. Now, I gave a talk to the hospice staff a couple of years ago. Dr. Sarkari kindly invited me to give that talk, and so I'm going to go over this entire talk with you right now, unless Taylor hits the skip recap button on the bottom right, and I'll only point to one slide. Okay. So the one slide I want to recap is this one that was taken from an article in the British Medical Journal by Sackett. And this is an important, I think, point of order. When clinicians and other healthcare providers are on the fence about cannabis use, they often say that there's not enough evidence. And what I believe they mean is there's not enough evidence that they feel comfortable with. There's different levels of certainty that each provider needs to have in order to bestow a certain treatment on their patient, and that's fine, and that's good. At the same time, there's a higher level of certainty that governments need to have before approving certain drugs countrywide. So that's why the FDA is more conservative, let's say, than yours truly. But I think a useful way to look at this whole issue is this diagram here, where evidence-based medicine turns out to be a function of clinical judgment on the part of the practitioner, relevant scientific evidence, the keyword there being relevant, because that would include not only randomized control, blinded trials, but also perhaps surveys, studies that don't meet the rigor of a randomized control trial, but still have important information to provide. And then, of course, patients' values and preferences. We can't ignore the experience of our patients when they want to partner with us in their health care. To do otherwise would be unfair and not productive for your practice. So I believe, and I have my own level of certainty that I need to achieve before I administer a certain treatment, but I believe that each of these different spheres of evidence are important contributors before making a decision about care for a given patient. I know that we invited Dr. Zarabi from Emory to the presentation today. I don't know if he's logged in or not. If he is, hi, Ali Zarabi. He has done important work at his university, and I reviewed some of his studies recently. He had 2 papers where he talked about a survey of 101 patients in Georgia that were using cannabis that came to the ambulatory palliative care center. And he made some important observations that I think add to our knowledge of how these medicines are not only perceived by patients, but what we need to be prepared for patients like Gloria to come. He observed that over 50% of patients actually felt that cannabis use would contribute to a cure to their illness, mostly cancer. And I've seen other studies that are surveys of patients using cannabis that also include a significant percentage of people that believe cannabis can help with a cure. Now, that's important information because we need to be frank with our patients about what they're using. We need to coordinate what they're doing with what we may want to do with them in terms of allopathic therapy. For example, in the cancer population, we have a class of medications called checkpoint inhibitors, which rely on our immune system to become active and exert their effects. Now, if you're using an immunosuppressant, like cannabis, might that not reduce the effectiveness of the allopathic therapy? Theoretically, that's possible. We have some evidence suggesting that it may be a real effect. So we have to look at that, and we have to have a conversation with our patients about what they're taking and how that might affect their other treatment. In the liver, cannabis is metabolized. THC and CBD are metabolized in the liver by the P450 enzyme system. And we have other medications that need to be metabolized, including tamoxifen, in order to become active. So if you have competing drugs that in a dose sufficient to reduce metabolism of one or the other, that needs to be part of the conversation. And we talked a lot about that type of interaction in the MS population because, prior to 1993, we did not have any immunotherapies for MS except for steroids. And once the interferon therapies became available, patients that were otherwise so desperate for treatment that they went to Mexico for bee stings and Laetrile were able to at least have a conversation with us about what complementary and alternative therapies they were using so that we could coordinate the allopathic and the non-allopathic therapies. And I believe we're going to hear more about integrative medicine later this afternoon. So what I want to emphasize is that there is plenty of evidence available. We have randomized controlled trials, we have surveys, and we have thousands of years of patients' experiences. So let's not hide behind the veil of not enough evidence. There's a mountain of evidence. And of course, we need to be careful not to make things worse with our patients. And I'm pretty sure it was Hippocrates that taught us to do no harm. First, do no harm. That's an important aphorism in medicine. And there's lots of these, and I'm going to use some others in the rest of the talk. So before giving a patient cannabis or recommending that they try cannabis, we want to make sure that we're not going to make them worse. Well, it turns out that cannabis is probably one of the safest medications available. I believe it's safer than Tylenol. In patients who are taking huge amounts of CBD, there can be some liver enzyme elevation if valproic acid is concomitantly being used. But in general, you don't get liver failure with cannabis. You just don't. Cannabis is so much safer than, for example, opiates or benzodiazepines to help with pain and anxiety because there's no respiratory depression with cannabis. So we do not have to worry that we're going to harm our patients with cannabis if we're careful about a few things and keep our eyes open about things that we still don't know about. But in general, unwanted psychoactive effects can be disturbing to patients. Those are usually short-lived and include a feeling not like oneself, perhaps. If you use enough THC, you can affect your ability to think clearly, and you can even have certain psychotic type symptoms. You can have paranoia. You may even have some hallucinations, but those are short-lived and due to high doses that once metabolized do not result in any lasting effect, except in a population where psychosis is a risk. And that would be in patients who have been diagnosed with schizophrenia or have a family history of schizophrenia and are at risk for developing psychosis. You do not want to give or suggest that those individuals use high THC products. It's not wise. However, CBD has an antipsychotic effect, and we have learned that CBD-containing products can work as well as some first-line traditional antipsychotic therapies for patients with schizophrenia. Motor effects, including muscle weakness and incoordination, are something we need to look out for, and of course we tell our patients not to get in the car or do other things that require dexterity, operating machinery and so forth, unless they are comfortable with their cannabis use and they have experience with it and they feel unimpaired. Drug interactions I alluded to earlier has to do primarily with metabolism in the liver, but also when it comes to the effectiveness of a certain drug. For example, opiates are really great drugs when it comes to getting rid of acute pain. They work quite well. If you use cannabis with opiates at the same time, there is a synergistic effect. And this doesn't have anything to do with liver metabolism, it just has to do with what's going on in the brain. Small amounts of opiates combined with THC will enhance the effectiveness of the opiates without increasing the risk of respiratory depression. This is a beautiful thing. In our population of palliative care patients and hospice patients that are using morphine and other opiates for pain relief, but dealing with side effects like constipation and changes in mental status, we can reduce the dose of the opiates by supplementing a small amount of cannabis and allow them to be clear mentally and have a functioning bowel. Very important. Cardiovascular effects also are something to consider when using cannabis. Cannabis in the inexperienced user at high doses can cause fast heart rate. Drops in blood pressure have been reported, and there have been isolated reports of coronary vasospasm, although those are quite rare. There's also legal, financial, and social risks that patients have to accept in certain situations, and of course we don't recommend patients break the law or empty the coffers when they're having to pay for their own CBD because insurance companies won't. Sorry, a little editorial comment there. I just had a conference with an interviewer in the United Kingdom who was highlighting the cost that patients otherwise covered by the National Health Service had to endure because even though the United Kingdom allows for medical cannabis, the doctors are not willing to prescribe it. And so the epilepsy patients that are dealing with things like Dravet syndrome are getting their CBD from the Netherlands and having to pay out of pocket thousands of pounds each month. So there's that. My take-home message here is that we have lots of safety information. You know, we use medicines all the time that have potential risks. We just do it with our eyes open, and we watch out for things. So when it comes to considering randomized controlled trials and the phase 2 safety data that may not be available for wide use in the cannabis population, I would say no, wrong, no thank you. We have plenty of safety data, and let's proceed with our eyes open. Now, this is another aphorism which I think is the rallying cry of the palliative care movement, is it not, Joelle? Or at least for some people. Can you see that last word, or is my big head in the way? No, it's my head is in the way. Can I move it out of the way? Let's see here. All right, well anyway, cure sometimes, treat often, comfort always. And that is an important phrase for what we do in medicine. Again, the multiple sclerosis population oftentimes required lots of comfort because we couldn't cure them, and the treatments were subpar for many years. We can treat mood issues with cannabis. Anxiety is particularly responsive to cannabis therapy. Depression, we treat with cannabis products that contain limonene, like that super lemon haze you were asking about earlier, Gloria. And we can also treat pain quite effectively with cannabis in most patients. Of course, there's many different kinds of pain. There's neuropathic pain, there's abdominal pain, there's chronic pain, not to mention spiritual pain and so forth. But there's different types of pain, and we have cannabis products that are available to help that symptom. Sleep is something we do really well with our cannabis products in our clinic. We have a very high success rate helping patients with sleep. Of course, we still have to do the evaluation to find out if their sleep disturbance is due to too much caffeine or the Ritalin someone else gave them. We have to promote sleep hygiene, and then we try to figure out whether or not their sleep is due to some other condition like restless legs or some other parasomnia, we call it. Initial insomnia, maintenance insomnia, and then we design a cannabis treatment protocol to help with that specific type of sleep or pain or mood disturbance. Gastrointestinal has been one of the reasons for cannabis use for many years. Back in 1986, FDA approved Marinol. Marinol is a synthetic THC molecule that was approved for use in chemotherapy-induced nausea and vomiting, and a few years later for HIV/AIDS-related wasting syndrome and cachexia. So Marinol, also called dronabinol, as a THC molecule, has been in our armamentarium for many years to help with those gastrointestinal issues. It turns out that patients don't really like Marinol because it can cause depression. There's a very narrow therapeutic window. And Marinol never became a drug of abuse, even though it's THC and is supposed to get you high. The reason is because it's one molecule. And our biochemistry requires a more balanced approach to activating the cannabinoid receptors. Marinol alone does not really work all that well except for those indications and only in a careful use. Another example of that has to do with rimonabant. A few years back, this medication rimonabant, which blocks the cannabinoid receptor, was thought to be effective in patients as a weight loss supplement because it was sort of the anti-munchies medication. What they failed to realize, even though there were phase 1, 2, and 3 studies, was that by blocking all the THC1 receptors, you create depression. And there was an increased incidence of suicide as a result. So while those patients were thin, they still wanted to kill themselves. So that was bad. And that was an example of single molecule paradigm thinking applied to plant medicine. It doesn't work. We need to use multiple molecules when considering how best to administer cannabis therapy. And so I'm a proponent of whole plant medicine And even though isolates of certain molecules of the cannabis plant can be helpful, it seems overall that when compared with a more whole plant approach, the results are better. The dose makes the poison, another aphorism. Now, in medication use in general, the dose can be helpful if appropriate, but cause side effects if inappropriate, and the same goes for cannabis. This Gaussian type graph was clipped from Dr. Sulak's healer.com site and represents what he describes as a biphasic response. Many cannabis therapies can produce benefits as the dose is slowly increased, but oftentimes there's a point after which the benefit no longer is present as the dose is increased. It's actually worse than that. In patients, for example, that have nausea and vomiting, you can start out using a small amount of cannabis and have a good anti-nausea effect. But after a certain point, if you continue to use high-dose cannabis, you can actually lose that benefit and get worse. There's a condition called cannabinoid hyperemesis syndrome, where the body's own regulatory machinery to prevent nausea and vomiting stops working normally because there's too much THC that has been used and the regulatory balance is thrown off. So those patients develop vomiting that won't quit. They end up in the emergency room getting endoscopies. Many of them discover that taking hot showers alleviates some of their symptoms, and that's an interesting from a biological standpoint. We could talk about that more in the Q&A if you like. The point I'm trying to just make here is that, like any other medication, dose is important. And as physicians, we can certainly handle that. The other thing has to do with the administration methods. There's different ways that patients can take their cannabis medicine, and that has a big impact on the effect due to the different pharmacokinetic profiles. So, for example, eating edibles, most of you know, create a delayed onset and a prolonged duration of effect, compared with inhaling the medicine, which is more immediate but shorter lasting. We have a lot of problems in states like Colorado and Oregon where people go for vacation and cannabis tourism and end up eating too many edibles. They end up in the emergency room, and that's something that the caregivers there are very familiar with because patients don't realize that after you metabolize THC, it becomes a more potent molecule and lasts longer. So they take more edibles, and before you know it, they can't get off the couch, and that's a problem. Protocols, how cannabis therapy changes over time. So, for example, when Gloria shows up and you're talking to her in the palliative care office, you need to talk with her about dosing strategies at the initial part of their treatment protocol, and then where you want to be. What is the target dose? What is the process of getting from point A to point B so you can get to the top of the curve, which is the optimal dose, without unwanted effects. This is certainly the art of medicine. We have to be smart about what we're doing here. We don't have randomized controlled trials about all the pharmacokinetics of all the cannabinoids and terpenes. We have to learn about that ourselves, and we have to administer it to our patients in a careful way based on what their experience has been with cannabis, what they're trying to achieve with their cannabis, and what time course they have to achieve that. So, one of the super helpful resources for me has been the Society of Cannabis Clinicians. Early on in my journey learning about cannabis therapy, I found the resources that were available for free at the Society of Cannabis Clinicians website were hugely helpful. And then, of course, I became a member and I had access to other information, including a presentation given by Valerie Leveroni-Corral this last year on how she treats hospice and palliative care patients in Santa Cruz, California. Valerie's story is super interesting, and I will refer you to the podcast Great Moments in Weed History, first season, I think the 3rd or 4th episode, to hear her story. I'll just leave it at that. But the Vimeo reference here on the slide is from the Society of Cannabis Clinicians website, and you can watch it there. Basically, what Valerie is doing is sharing with us her real-world experience with patients that are dying. And of course, this is invaluable. So I'm going to share some of her stories. Oh, what a coincidence. Gloria is a 66-year-old woman who had suffered for many years after her daughter's death at the hands of a murderer. She was diagnosed with lymphoma and underwent chemotherapy, but found that CBD, 10 milligrams, and THC in small doses was somewhat effective, and she increased that dose over 3 months. 63 milligrams of THC was her target, and I think what she was doing there was trying to reduce the tumor. Again, we can talk more about tumor modification hopes and dreams that patients have. We do have some science behind what is promising for some tumor types when it comes to reducing tumor burden using cannabis, but I'm not going to focus on that now. Gloria here at the end of life continued to use low-dose THC, 1 or 2 milligrams, with CBD, and her opiates were discontinued. At the end of life, her morphine small doses were restarted, again with THC in a synergistic way to stay ahead of the pain, and Gloria was relaxed, and she was actually able to forgive the murderer and die peacefully. Another patient of Valerie's, who again she ministered to at the bedside, and this may not be an example of what's practical in most palliative care centers, but what she did is remarkable. Her group, the Woman Alliance for Medical Marijuana, they have members out in California, and they provide cannabis for free, if necessary, to those members and follow them for years. And when they are in the dying process, they're accompanied by other members and Valerie at the bedside 24/7. In this case, Allie had hepatocellular carcinoma after hepatitis and had regular cannabis use and increased THC up to 350 milligrams a day. Now, when you take a gummy from your dispensary in Colorado, chances are it has 10 milligrams of THC. That's a standard dose. That's a lot for new users. But this patient was able to increase to 350 and then 632 milligrams of THC per day without vomiting, which can occur, as I indicated earlier, with high doses of THC, paradoxically. There was some tumor shrinkage, which I think was probably what they were hoping for, but 18 months later, this patient did enter hospice with pain problems that were effectively treated, again, with a small amount of morphine, 3 milligrams, and a 1-to-1 preparation of CBD to THC. What I mean by that is equal amounts of CBD and THC in a preparation are referred to as a ratio of 1-to-1 because they're equal amounts. And 45 milligrams of CBD and 35 milligrams of THC per dose is approximately 1-to-1. That's a very useful ratio to use because the CBD actually reduces the psychoactive effects of the THC, and patients can remain more clear in terms of cognitive function and are less likely to have side effects of the THC when the CBD is there. The CBD has benefits on its own, and Valerie uses high-dose CBD in her patients to reduce anxiety. But it's important to understand that the dose of the CBD to achieve that anxiolytic effect oftentimes is greater than 50 or 100 milligrams. Just as an aside, I digress. You will see CBD containing beverages and cookies and brownies all over the United States before too long. And those dosages will probably be on the order of 5 and 10 milligrams. CBD is hard to produce profitably unless you charge a lot for a little. And it's going to be, I think, a lot of placebo effect when people are using 5 and 10 milligrams of CBD. In fact, small amounts of CBD can actually have an alerting or energizing effect, 5 or 10 milligrams. And so when patients are using small amounts of CBD to help them with sleep and they can't fall asleep, that's why. If you increase the CBD dose to 50 milligrams, they will have more of a sedative effect. They need to get to the other side of the curve, as it were, of the pharmacokinetic clinical effect profile. But I do digress. Allie, in the final days, Allie was able to think clearly, communicate, and remain aware. She was able to enjoy hearing the poetry that Laura Huxley shared with Aldous Huxley, and I have a feeling some of our speakers later today will talk about Aldous Huxley and the work that he did with psychedelics. Nonetheless, Allie was able to experience an agitation-free death. I'll pick up the pace a little bit. I hope you guys are enjoying this as much as I am. And if anybody has any questions specifically about some of the details that I may have glossed over, you all can reach me, info@neurologyofcannabis.com. So feel free to reach out to me to carry on the conversation, info@neurologyofcannabis.com. Bonnie had uterine carcinoma and was not interested in THC. She didn't like it. It made her feel uncomfortable. And so, even though THC could have medicinal effects, it was Valerie's suggestion that Bonnie use a suppository and try to gain the benefits of THC without the psychoactive effects. And suppositories, it turns out, in general, do not cause psychoactivity. However, Bonnie did have some of that with the high-dose suppositories and then turned down the volume on the THC to low dose. Small amounts of opiates were added, and she remained cognizant the whole way through. Last case, David had esophageal carcinoma, and according to Valerie's description, was a very engaging and fun-loving guy. And in his journey towards the end of life, he was able to use high-dose CBD and moderate doses of THC with good result, but did need some morphine at the end. And then again, combined cannabis in a high CBD, low THC ratio. So that would be a 10-to-1, high CBD, low THC, along with small amounts of morphine every 2 hours as needed. This was effective, and he was able to remain alert and have a good death. So I believe that it's important for us to make these treatments available to our patients as soon as they are legally available, and we certainly have that situation in Florida. But there are obstacles to using cannabis therapy in hospice settings. In general, when there is a significant amount of revenue that's derived from federal programs like Medicare, those caregivers that also earn money from Medicare have a difficult time using cannabis because cannabis is still not legal on a federal basis, and there's a situation there where Medicare funding could be lost if cannabis therapy is employed. And hopefully, once cannabis is accepted countrywide and rescheduled from Schedule 1 to a more reasonable situation, then caregivers that rely on federal funding can also treat their patients appropriately with cannabis therapy. These patients are out of time. There's no time for randomized controlled trials in patients who are dying, obviously. And I would just want to mention that there actually is a group called Patients Out of Time, and aside from being a clever acronym, they provide a lot of really useful and interesting information on cannabis use. Patients Out of Time was started 25 years ago, and each year provides an excellent conference. There's other resources that are available, including the International Association of Cannabinoid Medicines, IACM, and the International Cannabinoid Research Society, ICRS, which meets every year and generates hundreds of scientifically based studies on cannabis, mostly from researchers outside the United States, but nonetheless, extremely valuable work. So those are the resources that I like to use to learn more about cannabis, and there's many others besides those. So, in summary, the endocannabinoid system is very real. Learn it. It's not going anywhere. It's actually going to become more complicated. So if you want to be part of this, if you want to enjoy the ability to treat your patients with cannabis, and I say that because it works, and it's a good experience being able to provide safe plant medicine for patients that have had it up to here with allopathic therapies that don't work. That population is so thankful that you can offer and guide them with this plant medicine. They want this option. There's plenty of evidence. Sure, we need more randomized controlled trials. We need that. Those are especially hard to do with plant medicine because of the lack of one molecule, one effect paradigm at play. And obviously in patients in the palliative care setting, it's unreasonable to expect randomized controlled trials to ever be performed. Cannabis is safe. I would say safer than acetaminophen or Tylenol. It works almost as well as snake oil, but we'll just call it cannabis oil. And the dosing strategies give the clinician an opportunity to work with each patient as an individual to determine the proper method of administration and dosing depending on their experience and what they want to achieve. And so I would encourage you fellows to go forth and learn about the cannabinoid system and what medications are available and how they can be used. But learning about it is not enough. You have to consider implementing it. As Sir William Osler said, to study the phenomena of disease without books is to sail uncharted sea, while to study books without patients is not to go to sea at all. So I would encourage you all to go to sea with your cannabis knowledge. Don't be afraid. Call me if you need help. Thank you very much.